Okay guys, so today we'll take a very simple but yet very misunderstood topic, that is your Endo-Perio lesions. Okay, now this topic I have covered mostly from Linde. Okay, Karansa does mention about it, but Linde has covered it, including all the recent advances which have been added, that is basically pertaining to your 2017 classification also. Okay, so it's a simple one. I have tried to simplify it as much as possible for you all. Now let's go ahead, dive deep into it. Coming to introduction part. Now, what is basically an endoperio lesion? If we talk about it, it is basically disruption in the physiological equilibrium between the periodontal tissues and the root canal complex. Now, whenever there is any physiological, as in there is any altered physiological equilibrium, it could be mostly it is due to injury. Now, this injury could be because of microorganisms or inflammatory products. So what happens is, most of the time which has been observed, there is a pathological communication. Okay, there is communication. There are communications such as accessory canals and of course your main canal, that is your apical foramen, which serves as a communication between your root canal complex and the periodontal tissues. Okay, but many a times what happens whenever either of these two things, okay, either your periodontal tissues or your root canal complex, they are suffering with some sort of pathology, this communication becomes pathological. Now, mostly it is contained in when you go for an RCT, that is root canal procedure, root canal treatment. But in case if there is a serious damage, then what happens? It will lead to endoperio lesion. Now, how do you identify? You see altered sensitivity test with respect to the root canal complex. Your pulp sensitivity test become altered, and there are deep periodontal pockets associated with the periodontal tissues. So these are some very common signs and symptoms observed with respect to your endoperio lesion. So this is simple. Basically, a pathological communication between your periodontal tissues and root canal complex is what we call an endoperio lesion. Now, coming to the classification. So the first classification, not first, but actually the most followed classification is given by Simon et al. In 1972. So he basically assumed, okay, it was based on an assumption that now a lesion progressed because it was primary endodontic, as in the endodontic lesion was the first one to occur, which later led to periodontal lesion and then maybe combined lesion. Okay, so how he classified was primary endodontic, as in the endodontic lesion is the primary source of infection, then primary endodontic with secondary periodontal involvement, then primary periodontal lesion, primary periodontal with secondary endodontic involvement, and a true combined lesion, as in both the lesions are progressing at the same time. Now there were some serious drawbacks. Okay, some questions were raised regarding this particular classification. Now, it was not practical because once a lesion is established, it is difficult to actually find out the origin, like which happened first. Okay, you can only assume, okay, this could be because of endodontic or this could be because of periodontal progression, but most of the time you don't know which one was the first cause or which one was the true cause. Okay, then regardless whether it was perio or whether it was endo, the treatment for EPS remain the same, right? It is not really relevant whether the primary source was endodontic or periodontic. Now, both your periodontal ligament and root canal will need treatment. Even if it is periodontal ligament responsible, or you can say the, sorry for that. Yeah, even if the periodontal ligament is the culprit, you will have to treat the root canal regardless. Okay, it goes without saying. So these things were the reason why this was not followed later, but of course many clinicians do follow it, and that's okay. That's up to them. Now moving on to the 2017 classification, which was given in the World Workshop European Federation of Periodontology by Catlin Herrera and Papapunau. You need to remember this name if you're a PG. Okay, now this new classification is based on the prognosis of the tooth. So prognosis, we all know what prognosis is. Basically, the path or the possible, you can say, progression taken by the disease. It could be good, bad, poor. Now that is another, you can say another video, the prognosis. Now for now, you understand what the basic meaning of prognosis is. I take it for granted that you do. Now moving on. So basically, prognosis of the tooth, what does it depend on? It depends on presence or absence of root damage. We all know if there is root damage, if root damage has already occurred to a tooth, then the prognosis would be most of the time poor. Okay, so this is the first thing. Second thing is presence or absence of periodontitis. Now periodontitis, why periodontitis? It leads to poor prognosis because if the periodontal ligament of a tooth, okay, this is your tooth, if the periodontal ligament is compromised, then of course this tooth will later just like, okay, see ya, I'm going. It will loosen out, it will go mobile, and then later it will fall off. Okay, so of course periodontitis leads to poor prognosis. Then extent of periodontal destruction around the tooth. We know that if, for example, if there is horizontal bone loss, this is horizontal bone loss in a tooth. Okay, both the sides are the same. Okay, then the vertical bone loss is, it occurs something like this. Okay, this is vertical bone loss, right? Now, depending on which kind of bone loss is happening and how much of it has happened, whether it's up till 1/3 of the root, okay, 2/3 involving 2/3 of the root, involving more than 2/3 of the root, then of course all of these factors, they contribute towards the prognosis of the tooth. Very important factors. So 3 things that we saw in the prognosis of the tooth, that is, first is your presence or absence of root damage, then periodontitis, presence or absence, and the extent of periodontal destruction that has taken place. Now coming to the classification, so endo-perio lesion. Here in endo-perio lesion, they put it into 2 categories, that is with root damage and without root damage. Okay, now with root damage could be of basically 3 types that we see. Either it could be fracture or cracking, root canal or chamber perforation, maybe while performing an RCT, or external root resorption. Now there could be n number of other root pathologies. These are some few of them which have been listed here. Then coming to the other one, that is endo-perio lesion without root damage. Now it could be again of 2 types, endo-perio lesion in periodontitis patients or endo-perio lesion in non-periodontitis patient. Now in case if it is endo-perio lesion in periodontitis patient, then again we classify into grade 1, grade 2 and grade 3. So grade 1 is basically when there are narrow pockets in one tooth surface, grade 2 is wide and deep periodontal pockets in one tooth surface, and grade 3 is deep periodontal pocket in more than one tooth surface. Be very careful, they're mentioning about tooth surface, they're not saying more than one teeth. Okay, we are calculating the prognosis of a particular tooth, not the dentition. Okay, so be careful about that. So grade 1 is narrow, deep pocket in one tooth surface. Then grade 2 is wide, deep pocket in one tooth surface. And grade 3 is deep periodontal pocket. It could be narrow, it could be wide, could be any of these in more than one tooth surface. Okay. So these are your 2 classification, with root damage, without root damage. Now without root damage is again classified into in a periodontitis patient or in a non-periodontitis patient. Now one thing worth considering is, if it's a non-periodontitis patient, then how come they have pockets? Now, one thing worth noticing is, if the patient does not have periodontitis, it means these pockets are because of a localized lesion. Localized lesion as in which is due to the endopathology. Okay, so something worth noticing, because that really did meddle with my head, as in why are they classifying into grades if the patient does not have periodontitis. I thought about it for a while. Now coming to prognosis we know could be hopeless, poor or favorable. Now again it depends on the root damage. Most of the time when the root damage occurs, it leads to hopeless prognosis. It also depends on the extent of periodontal destruction around the affected tooth and presence and severity of periodontitis in the mouth. Okay, because what happens, infection, if one tooth is infected, okay, this one tooth is infected, so infection foci from this tooth tend to transfer to other teeth also, because of course they are present in the same mouth, right? So we don't treat one tooth. If the patient has periodontitis, we actually go for scaling and root planing for the entire dentition. Now here if you have heard about one stage full mouth disinfection protocol, now that also operates on the same principle, that if you eliminate all the infection foci in one go, then there are less chances of recurrence. Okay, so now that's for another time, but yeah, some pearls for the pros. Okay, now moving on to etiology. Etiology could be, again, either could be because of trauma or iatrogenic factors. Okay, origin could be non-infection. For example, if the patient fell from a cycle, then yeah, trauma, it is non-infectious. Then prognosis, again, depends on that, whether it could be hopeless or it could be poor. Then etiology depends on trauma. Etiology is basically could be because of traumatic reasons or iatrogenic reasons. When we talk about traumatic reasons, it could be root cracking, root resorption, okay, or pulp necrosis. So whenever we have noticed there is trauma to a particular tooth, either it goes for fracture, or there many times we see external root resorption, or because of trauma the pulp undergoes necrosis. So these are because of trauma. Then iatrogenic is root chamber or furcation perforation, mostly caused due to RCT treatment. Okay, so this is your one type of etiology, trauma iatrogenic factors. Then we have your infection one, as in which involves infection, that is your endodontic and periodontal infections. When we talk about endodontic, in endodontics, most of the time the tooth is carious. So carious lesions of the pulp, which secondarily involve the periodontium, okay, as in the periodontium was not involved earlier, but the carious lesion, the carious foci, the bacteria spread from the endodontic or from the pulp to the periodontium. Okay, now we have the periodontium which is infected. Then periodontal destruction. Periodontal destruction which secondarily affects the root canal. Okay, because we know that there are many communication, accessory canals, apical phenomena. From that, the infection foci can transfer to the root canal. Okay. Now, how periodontal destruction impacts the prognosis. This is also worth noticing. Now, what happens, there are striking changes in the ecology. If you guys might have heard about the IMPEDE model. Okay, it is really important and I'd suggest that you read it. Okay, if you're a periodontist, then it's very, very important for you. If you're a PG, then there is also a keystone pathogen hypothesis. Now, which says that P. gingivalis is basically the keystone pathogen responsible for progression of periodontitis. Okay, so what happens whenever there is dysbiosis? So mostly we exist in a condition of symbiosis, as in there is no disease. Okay, but when this moves to dysbiosis, as in the diseased organisms, they increase in number, and what they do, they start destruction. Okay, destruction of the tissues. Now in that case, of course, you see striking changes in the ecology, which converts the healthy state into a difficult, or yeah, of course, when they convert healthy state into a disease state, it becomes a difficult task, and patient starts suffering from advanced periodontitis and deep pockets. Okay, so advanced periodontitis, deep pockets basically means your clinical attachment loss, and if there is clinical attachment loss, of course, the attachment apparatus has become weak, so there are high chances for a tooth to fall off. Okay, so that's why periodontitis actually directly impacts the prognosis of an EPL. Now both the lesions, if they occur simultaneously, it is your true combined lesion. If you see them simultaneously, it's a true combined lesion. Okay, so up until now what we have covered the introduction part, then we talked about the classifications, now etiology, now moving on to the microbiology part. So the microbiology, as we know, can be assessed by culture methods, check about DNA hybridization. I will not be covering them in detail here. Okay, you can go ahead and read about it. Then next generation sequences and denaturing gradient gel electrophoresis. So these are all some sophisticated methods to study microbiology of your lesion. Now, what has been observed is a marked similarity in the microbiota of root canals and periodontal pockets. Now, this is very obvious. It actually makes sense because root canals and periodontal pockets are in communication. Okay, they're not isolated. They are communicating with each other. Okay, so what happens? The root canal, for example, if there is a lesion, that is your necrotic pulp or endodontic infection, the pulp space is exposed, or it could be unexposed also. Either of the case, these will directly affect the periodontal pocket or the periodontium. Now, in periodontium, you see red or orange complex bacteria, which is basically the primary source of infection. Now, what was found that even in the root canals, whenever there was any infection or EPL, we saw red complex and orange complex bacteria. So turns out that these are the primary source of infection regardless it is an endodontic or periodontal lesion. Okay. Now moving on to pathogenesis and histopathology. So in pathogenesis histopathology, we will talk about the communication pathways. Okay. So communication pathways, we know that pulp and periodontium, they communicate with each other, right? How do they communicate? Through dentinal tubules. Not through dentinal tubules actually, I'm sorry for that. But yeah, apical and radicular foramina and accessory or lateral canals. Now, one thing worth noticing is under natural conditions, under normal condition or in a healthy state, these communications are aseptic. Okay, they do not have any infection. They're aseptic normally. Okay, but what happens whenever there is any pathological communication? Okay, they allow these microorganisms or their byproducts or inflammatory mediators from root canal to the periodontium or the periodontium to the root canal. Could be either ways. Okay, so now periodontium. Now periodontium basically it causes positive association in pulp alterations. What happens whenever there is a periodontal lesion? What happens is it directly causes pulp alterations. How does it alter the pulp? It alters the nutritional supply of the pulp. Then it also may lead to necrosis or atrophic changes and degenerative changes. So we have to keep it in mind. Okay, the pulp alterations which are caused by periodontium. So this is a positive association. Okay, now how does the pulp affect? The pulp actually becomes necrosed due to abscesses, which leads to localized attachment loss and bone destruction. Now, these are mostly drained through gingival sulcus or periodontal pockets. You might have noticed many times patients who come with chronic apical abscess or periodontitis, they mostly have draining sinuses. Because what happens, the pulp is a closed chamber. Okay, so from a closed chamber, the pus needs to drain. So how will it drain? It will find the pathway of least resistance. Okay, pathway of least resistance. Okay, and that is your buccal plate. Your buccal plate is very thin, or could be lingual plate depending on the location of the tooth. Okay, location will determine where this draining sinus will form. Okay, now moving on to our next part, that is your risk factors. So the risk factors for an EPL could be your advanced periodontitis, could be trauma, could be iatrogenic events. It's very easy. Like, think about what can cause your EPL. Could be the endodontic or periodontic. List all the periodontal causes, list all the endodontic causes, and you're done. Then grooves, palatal grooves, then your porcelain fused to metal crowns, and active caries lesions. So these are very common risk factors which lead to EPL. Then coming to clinical presentation and diagnosis, so it given by Catton, Herrera and Papanappanao in 2017 World Workshop. So EPL, as we have figured out, is a pathologic communication between the pulpal and periodontal ligament. It could be acute, that is your symptomatic one, could be chronic or asymptomatic one. Coming to most relevant findings which are seen when we talk about an EPL is deep periodontal pocket, which is close to the apex. Why? Because unless it is close to the apex, the pulp will not be compromised. Okay, we need it to be close to the apex if we want, in order to diagnose it as a EPL and a EPL. Now, with respect to the pulp also, you see negative or altered sensitivity test. Then there can also be some recent trauma or iatrogenic event which may lead to root fracture or perforation. So these are very common or relevant findings. When you take patient's history, they might reveal either of these things. Okay. Coming to signs and symptoms, mostly you see bone resorption, could be apical or in the furcation region depending on the tooth. Then there is purulent exudate because of infection, tooth mobility, sinus tract, presence of a crown or gingival color alterations. So these are also seen. Now coming to the diagnosis part, this is very important. Pay attention. So first of all, anamnesis, it means you ask the patient questions, relevant questions, then the patient answers. After that, you go for clinical findings. Clinical findings include your both clinical and radiographical. Here you will evaluate for perforation, fracture, cracking, or external root resorption. In case they are not identified, then you go for second stage. That will cover. Now, after clinical findings, of course, you also go for patient history. This I may have mixed a little. Patient history is always first, of course. Now, in patient history, patient might reveal occurrence of trauma, previous endodontic treatment or instrumentation, and post-preparation. So these things mostly are responsible for your endo-perio lesion. Now, coming back to your clinical radiographical findings, you evaluated, you checked for all these things. Then if they are not identified, the second stage involves full mouth periodontal assessment. It means the patient does not have any of these things, means there is no root damage. Okay, that will cover. Then in full mouth periodontal assessment, you check for sinus tracts. For sinus tract, what you can do is you can use a gatta parcha and insert it into the sinus tract and take an x-ray. That will help you identify the path of that sinus. How do you go for periodontal assessment? Go for probing pocket depths, presence of cavities, then attachment levels, bleeding on probing, suppuration, mobility, sensitivity test, whether the pulp is vital or not. Okay, so many times if the host immune response is very high, the pulp might be vital. Okay, otherwise in many cases or most of the cases it is altered or negative. Okay, now moving on. So this is the chart which is mentioned in your Linde, and very simple one to go about. I'll just briefly explain this because I have covered everything very in a lot of detail later. So patient will come to you either with the chronic or acute. In acute, the patient will be symptomatic, may present with either pain on palpation, percussion, mobility, either of these things. Then you check for recent trauma, ask the patient, take history, go for clinical examination, sinus tract abscess, deep pockets. Then you take the radiograph of the symptomatic tooth area, look for endodontic treatment, post, retained restoration, peri-apical lesion, fracture, cracking, perforation, anything that you can think of. Okay. In case there is fracture, cracking or perforation, you find any root pathology, then it is EPL with root damage. Diagnosis done. Then if there is no fracture, cracking or nothing of this sort, then you go for full mouth examination, full mouth periodontal examination and sensitivity test. Now here what do you see? If you don't see any, if you don't see any of these fractures, cracking, perforation, external root resorption or with deep or altered sensitivity test, then it is EPL without root damage. In that case, either periodontitis could be there or not. If it is there, then EPL in periodontitis patient, you again classify into grade 1, grade 2, grade 3 that we covered earlier. And in non-periodontitis patient, again grade 1, grade 2 and grade 3. Okay. In case, now, not in case, actually now moving on to your asymptomatic patient. Asymptomatic means the patient is suffering from chronic, okay, does not have symptoms right now. Here you will go for clinical detection. Now this is mostly when the patient is showing up for any routine procedures. There you might detect a very deep periodontal pocket, okay, a sinus tract groove or asymptomatic abscess on a radiographic bone loss close to the apex. Then again you go for check. You ask the patient, take history, okay, whether any endodontic instrumentation, post preparation was done. You go for radiography, look for endodontic treatment, post, retained post, periapical lesion, fracture, cracking, everything, okay. Then you go for full mouth examination, periodontal sensitivity test, pulp sensitivity test. In case you find any fracture, cracking, perforation, external root resorption, then EPL with root damage. If not, you don't find any of these, then again we'll follow the same path, and this is cool. Moving on to treatment of endo-perio lesions. Now, this is very important and also pretty challenging. Why is it challenging? Because it is associated with poor tooth prognosis. Why poor tooth prognosis? We covered it. Why? Because most of the time it will have root damage or it will have periodontitis. Both of these cases, both of these conditions have poor prognosis on the tooth. Okay. Now, one thing worth noticing is that not all EPLs go for extraction. Many times they are treatable also. Okay. And once treatment is done, the prognosis might become favorable over time. So now, how do we actually figure that out? We need to have an understanding about the factors affecting it. That is your biological factors which are crucial for effective treatment. Okay, so dentistry is not just about you went ahead and did the RCT, did scaling and everything. No, it is about having a clear mindset. Okay, clear mindset where you are very clear about the etiology. If you are clear about the etiology, you can go for excellent treatment. Why excellent treatment? Because if you know the cause, it's easy to eliminate it. But if you don't know the cause, you'll be working, you'll go ahead, give treatment of n number of times and n number of things, but still the patient will show up with the same problem again and again because you have not treated the cause. Okay, so in prognosis, as we have understood, that it helps us determine the course of the disease. Okay, what course the disease is taking, it helps us determine that. Let's take green. Okay, now coming on to the criteria for prognosis. Of course, as we already understood, it's first of all is the presence of or absence of root damage. Okay, then second thing comes is presence or absence of periodontitis, then anatomic problems as in grooves, then severity or extent of periodontal defect with respect to the affected tooth. Okay, simple, straightforward. Now, three main prognosis that we come across are your hopeless, poor and favorable. So your hopeless prognosis is directly linked with root damage. How? Now, one question that arises with most of the clinician might have actually asked themselves and come across is, should endo-perio lesion with hopeless prognosis be treated or not? Okay, you know that the tooth might go for extraction sooner or later. So should you give the patient that pain or make the patient go through that pain twice or not? Now this is again a matter of debate. Why? Because there are multiple biologic complications involved, and also the literature, when you go for evidence regarding it, it mainly has case reports and series which show the cases with favorable prognosis. Okay, now this is also something called as publication bias. As in, you tend to publish the cases or tend to publish the findings which are positive. So we actually don't get to know a lot about which treatment does not work, okay, or which particular condition has a poor prognosis. Now, there are unconventional therapeutic options also associated, such as intentional replantation of teeth. General questions which should be asked before determining the real viability of the tooth is whether the tooth will be used for prosthesis abutment or would be needed for indirect rehabilitation. Now, in either of these cases, the tooth needs to be saved. Okay. Now, in multi-rooted tooth, most of the time you will come across poor prognosis, or you'll find out that the prognosis is pretty poor. Why? Because, of course, multi-rooted tooth. Then what do? We actually don't extract it and we leave it in the mouth to be lost over time. Now, in case the patient needs complex rehabilitation, in that case, we'll have to check whether we can treat it. But there are many treatment options involved, which include your hemisection, okay, or root resection, right? Then bicuspidization. Then there are many treatments available here. Depending on your case, you can select one. Now, coming to steps in management of an endo-perio lesion. Again, these are critical tasks, some critical tasks that we need to determine or do before we go ahead for treatment are to determine the differential diagnosis between EPL, that is either whether it's with root damage or without root damage. This will basically determine your course of treatment. Okay. Then you also determine whether or decide whether you want to extract the tooth or maintain the tooth. In case you want to maintain it, then you'll have to go for full mouth periodontal assessment. Okay, after that we'll enter the treatment phase of endo-perio treatments or lesions. Coming to differential diagnosis. So basically you diagnose EPL into with root damage or without root damage. We have repeated n number of times now. First of all, go for a nice robust history. Then you go for clinical and radiographic examination. What do you look for? You look for deep pockets, sinus tracts, abscesses, cracks, fractures, perforation, or external root resorption. In case any of these are found, then what do? It could be either detected or not detected. Either of the case, you make a decision. You make a decision whether you want to extract the tooth or maintain the tooth. Okay. Now, if there's an EPL with root damage, you have to determine the extent of damage. Okay. How do you do that? You evaluate the chamber, that is your root canal perforation. For root canal perforations, if it is treatable, you treat it. How? The success here also depends on the size of the perforation. If it is small, it shows the best outcomes with MTA, your mineral trioxide aggregate. You can go for that. Then location also matters here. Time of diagnosis, if early diagnosis, prompt treatment will give you best success rate. Then severity of the periodontal destruction. The periodontal destruction is high, there are low chances of it succeeding later. Then biocompatibility of the repair material used. If in case, for example, there was a perforation earlier or when the dentist was treating but later he repaired it with a poor material, as in which was not very biocompatible, then later the prognosis becomes poor. Okay. Then if there is a complete vertical fracture, this will directly go for extraction. You can't do anything about it. Straight up extraction. Now, if it is incomplete, then you can go for periodontal surgeries such as episectomy or regenerative procedure. Also intentional replantation after RCT. Okay. Now, so this was about with root damage. Okay. If you want to maintain the tooth, we were making a decision whether you want to maintain or extract. If you want to maintain the tooth, first we check whether if there is root damage. Then we go for full mouth periodontal assessment. What do we do here? We check for the extent of periodontal destruction around the endo-perio lesion involved tooth. We check for mobility, periodontal pocket depth, attachment levels, presence of cavities, bleeding on probing suppuration, and tooth vitality. Everything is included here. Now, in case there is root damage involved, what do we do then? Then we go for rehabilitation. Okay. and we decide whether it should be maintained or not. If it is maintained, then you go for endoperio treatment. Now here, endoperio treatment, one question which is most commonly asked and which is very confusing for young periodontists or endodontists, that which should be done first, whether RCT or SRP, that is your endo treatment or your perio treatment. Now, in a systematic review by Schmidt et al. In 2014, you guys can refer to it. He mentioned in that most of the clinicians have performed RCT first, as in you go for RCT first. Why? Because it gives time for periapical and periodontal healing. It facilitates periapical and periodontal healing, and the time which is given, as in the gap between RCT and SRP, is roughly around 1 to 3 months, also depending on the healing time. If the patient is young, then you can go for SRP earlier, after 1 month, but in case the damage is high and the lesion is pretty, as in like lesion has progressed a lot, then of course you'll have to wait. After SRP, you can go for regenerative procedures again if necessary. So this was pretty much all about, okay, we missed one point. Yeah, with root damage, presence or absence of history of periodontitis. Now, if there is periodontitis, we also check for severity. So in endoperio lesions, of course, two things are very, very important. That is your endodontic aspect and your periodontal aspect. If you're very clear about that, then of course you will be able to treat it successfully and promptly. Now, thank you so much for listening. Let me know if you want me to cover any other topic.